Good afternoon. My name is Emily Austin, Managing Director of Cooper Surgical UK and Ireland, and a very warm welcome to our webinar today, How to do an Embryo Transfer. It's really wonderful that so many of you have joined the webinar today. Thank you so much for tuning in. Speaking in the webinar today, we're delighted to have join us Melanie Collenette. Mel qualified as a nurse in 1994, specialising in acute surgery and high dependency care. She is now a senior nurse manager with nearly 20 years' experience working with infertility. Mel has worked for a number of well-known fertility clinics, both in and outside of London, with responsibility for managing the nursing and clinical services, as well as having led on HFEA, CQC and quality management inspections. Mel is fully trained in all aspects of fertility nursing, including gynecology and early pregnancy ultrasound, and extended her role in 2007 to include embryo transfers and later egg collections in 2016. Mel is passionate about delivering optimal patient care and supporting her patients from consultation to embryo transfer. And also joining us today, a big welcome to Mr. Amit Shah. Amit is a consultant in reproductive medicine and surgery at Homerton Fertility Centre, London. He also practices privately in Harley Street. Amit enjoys teaching and training the next generation of doctors, scientists and nurses, and participates in various national and international training programmes. Amit has been practicing the art of embryo transfer for over 20 years and has carried out more than 3,000 embryo transfers with excellent success rates. Also joining us today, a warm welcome to Sarah Fry, Senior Global Product Manager, Embryo Transfer and oocyte Collection here at Cooper Surgical. Sarah has worked with the Wallace brand since 1998, beginning in R&D and then moving into product management. Sarah joined Cooper Surgical in November 2016 following the acquisition of Wallace, and is responsible for the product management of embryo transfer, oocyte recovery, IUI solutions and theatre equipment. And then also joining the webinar today is our very own Helen Cooper. Helen has a BSc in Human Biology and an MSc in Reproductive Biology from the University of Edinburgh, where she focused on human sperm physiology. Helen went on to train as an embryologist and after 3 years in UK clinics, moved into women's healthcare sales. Helen joined Wallace in 2005 as Senior Sales Specialist and then as the UK Business Manager, with particular focus on training and education. Along with the Wallace brand, Helen joined Cooper Surgical in 2016 and is now a UK Account Manager, and she continues to support the UK on all things catheter related. And Helen is chairing today's meeting, so Helen, I'll hand over to you now to get proceedings underway. Thank you.
Lovely, thank you Emily, and thanks everyone for joining us this afternoon as we tackle the subject of how to do an embryo transfer. As Emily said, I've had the pleasure of working with the Wallace brand for almost 16 years now, and in that time I've learned that a really good embryo transfer starts with a really good embryo transfer catheter. Lots of people already know that Wallace created the first ever embryo transfer catheter, and over 40 years later Wallace continues to be the gold standard in embryo transfer, and I hope everyone who requested the demo pack has received it, and it's at the ready. And I'm going to hand over in a minute to my colleague Sarah, who, as Emily said, is the product manager here at Cooper Surgical for needles and catheters. And Sarah's going to talk a little bit more about what makes a great embryo transfer catheter, and you can join in with a presentation by getting a good look at the design features of the catheter in your webinar pack. So over to you, Sarah.
So a recap on the history, as Helen said, over 40 years ago, the first Wallace catheter became commercially available. But this all started a little bit earlier than that with a guy called Harry Wallace, who worked with the pioneers of IVF, Professor Robert Edwards and Patrick Steptoe. And together they created the very first Wallace embryo transfer catheter that we believe that Louise Brown was conceived with in 1977. So following Louise's birth, we launched Wallace catheter first time in 1980 for sale, and it's still going strong, the same properties of this catheter and new developments, and since 2016 this became part of Cooper Surgical. So for those of you who have the packs at home with the catheters, hope you've got them at the ready. What I'm going to talk to you about is the Shah Pro Ultra, which is the catheter we believe is the best for all routine transfers. And what's really especially good about it is it comes with a very soft obturator. So that's the second part of the outer sheath here. And then you have the soft obturator, which the end is 5 centimeters here, is soft and has no rigidity to it. What that does is once it's inserted into the outer sheath, becomes a good device that can carefully navigate the cervix softly and atraumatically. It has a very smooth tip once put together and the hubs are engaged. So this will tunnel through the cervix, hopefully getting through any mucus and bacteria, protecting the inner lumen, ready for when the transfer is going to come along. So let's talk about the inner part of the catheter. It has a supported metal inner, and this particular one has the echogenic SureView bubble technology in it, which means it's fully visible under ultrasound. And you can see on the slide there how the cross-section view looks of this catheter. So it has a very solid inner wall, so no embryos will get trapped in there. And the bubbles on the outside allow this to light up within the cervix, as shown in the ultrasound image as well. So once you've made your pathway with the obturator and the outer sheath together, remove the obturator and feed in the inner. So therefore it gently goes through, confidence for the clinician, and also no problem there with the patient with difficulties before the embryo comes out from underneath the hood. So we have various options of SurePro. This is just one, and this is for every routine situation. But what we offer for a difficult situation is a very similar version of this, but with a stylet. And the difference will be that the stylet is rigid to the tip. It's used in exactly the same way, and the properties are exactly the same in terms of the echogenicity of the inner and the outer dimensions and specifications. We also provide a single stage if you're doing a one-step transfer, but the obturator or the stylet will provide two-step transfer options, obviously the obturator for elective routine and the stylet for a difficult. If you have any further questions regarding the catheter and its properties and specifications, either put some questions in the chat later on, visit our website, or contact me directly. And now I will pass you back to Helen.
Sarah, I know that was difficult because it's a whistle-stop tour of the SurePro range, and you could have spent probably hours talking about our fabulous catheters. And I'd like to add that Sarah will be happy to answer any questions that you might have on the catheters, and we'll try and include these in the question and answer sessions towards the end of the webinar. So now I just want to introduce Mel. So in my time working with Wallace, I have learned anything. It's that I've learned that no two embryo transfer practitioners will perform an embryo transfer in exactly the same way. It's about finding the right technique for the individual practitioner. That said, there are ways to help ensure that the embryo transfer goes as smoothly as possible. So I'm delighted to hand over to Mel now, who's going to talk through some aspects of best practice and share some tips and tricks. So Mel, the burning question, how do you do an embryo transfer?
Thanks, Helen, and thanks Cooper Surgical for having me here. I do have my trusty little demo kit, which I will try and angle as best as possible for everyone to see. But if I get a little bit of distortion, I will keep checking that I'm getting the angle as correct as possible. So I've been doing transfers for about 13 years, and over that time, there's very little that I've changed in my technique. My demonstration is purely what is personal for me. It gives me good results, and just as importantly, that the patients themselves experience hopefully a comfortable process with a good result at the end of it. So I do tend to have a look through the notes before I do the transfer itself. Have they had a previous transfer? Have they been difficult? And whilst the patient is getting ready, that's what I will get sorted to start off with. I was taught to do transfers under ultrasound guidance, and I still do. I've worked with many doctors that don't use ultrasound at all, but it seems to be good practice nowadays. And the only tip that certainly was helpful when I was taught was, unlike how I would scan for a pregnancy scan or a gynae scan abdominally, actually rotating the probe around so that the leading edge is pointing towards the patient's feet means that the image on the screen is anatomically the same as your patient, if you like. So cervix is to the left of the screen and the fundus is to the right. So up is up, down is down. And if you do have any tricky aspects of a transfer, you can follow it very, very clearly on the screen. I'm also particularly fussy over who I get to scan for me, as anybody who is listening who has scanned for me will confirm. I think their role is just as important as mine, and also the embryologist, because a good image is what we're after. So first things first, lovely speculum. Most of the time a standard medium speculum works perfectly. Exceptionally tall women reporting difficult smear tests or previous transfers, a Winterton's usually resolves that problem, but a medium is what I would ordinarily start with. This one's a little mini one for my little mini kit here. I would obviously normally be wearing sterile gloves as well. So once patient's in position, speculum gets inserted, and I've got a very anatomically beautiful cervix in front of me, so not an awful lot of playing around to be done here. Just bear with me while I just get this in. Now, I'm not sure how much you can see of this, probably not an awful lot, but the cervix is directly ahead of me there. So at this stage, I would have my instruments already, and the embryologist would bring out the catheter. The catheter I use happens to be the one that Sarah's already told you about, which is the Shah Pro, which is the 2-stage catheter. So an embryologist will bring this out, and I will take my part. The embryologist will take their part back to the lab to load. Looking at the image on the screen, I do have a habit of playing with my catheters and bending them to the aspect of the uterus that I've got in front of me. Again, it can just help it go in easier, and with the soft obturation, it's very easy to do that. So on my little demo kit here, I can get my catheter in place. And once I have this in place and I'm happy that I've got to the internal os and no further, I will then remove the obturator and call for the embryologist, who will come in with their part. Now, ordinarily, because I would have an extra pair of hands with me, I would hold the catheter in place and the speculum, and the embryologist would come through with their bit, but I'm going to let go. And I will. So embryologists will come through, and I will ask them just to guide the tip of the catheter in as I'm holding my part. And I will then take this aspect, holding the syringe on the barrel of the syringe, so that there's no risk of depressing the plunger before we're ready to put the embryo back. Obviously, we wouldn't normally have a 3mm syringe on an embryo transfer catheter, but it's what I've got here. So catheter will be slowly inserted, and again, I'd be watching the image on the screen. You may be able to see, if I move this, the catheter actually appearing into what would be the uterus here. Because the catheter is echogenic, I'll be able to see it on the ultrasound scan. And again, the nurse or the healthcare assistant scanning for me, I would get them to follow the catheter as it goes through. Once I'm happy with the placement, very, very gently push down onto the plunger of the syringe. And as much as patients like to see the little flash on the ultrasound. I also like to see the little flash on the ultrasound, especially if you feel like the transfer hasn't felt quite right. Sometimes if you don't see the flash, you're more likely to get the embryologist tell you that the embryo has been retained and has to be reloaded. Once I'm happy with placement and I've depressed the plunger, so mid-cavity, I'll then rotate the catheter 90 degrees whilst still applying pressure to the syringe, and that should break any surface tension on the end of the catheter, especially if there's any mucus plug or such like. And then slowly withdraw and then pass that back to the embryologist for checking. Leave the speculum in place. For different transfers, sometimes I'll leave the outer part of the catheter in place and just return the inner so that it's easier to reload if I need to. But if everything is good and we get the all clear from the embryologist, speculum gets removed and we can get the patient back into a comfortable position. One thing I would say is I've never, in the very many transfers I've done, used a tenaculum. I've always used the speculum to try and change the positioning of the cervix. And I don't use any lubrication on the speculum, just plain saline, which again is what I use to clean the cervix. So saline to clean, saline on the speculum. And if it's in any way difficult because the patient's quite tense, very, very small amount of lubricating gel just on the blade of the speculum itself, certainly not at the end. You don't want to risk any transmission of that gel into the uterus. Once the patient's comfortable and a little bit of a chat through medication and what happens from there, one of the advantages of being a nurse is you can actually do all of that all in one part of the actual embryo transfer itself without having to hand over to a colleague, which is good. And that is a little whistle-stop tour of how I do my embryo transfers. And hopefully I've not missed anything. So back to Helen.
Thanks so much, Mel. I think that was really brave to have a go at that, because trying to demonstrate embryo transfer at the best of times, you know, when we're face to face, is hard enough, isn't it? But to do that with a model and through a webinar, I think is brilliant, and you did a fantastic job. So thank you very much. And I can see some questions coming in from our audience, so thank you for those too. I'm hoping we'll be able to get to those questions today. If we can't, we'll try and get back to you at another time, and we'll try and answer those questions for you. We'll hope to try and tackle as many now, though, in a Q&A session with our panel. And we'd also love to encourage all of you to make any suggestions you have for any future Cooper Surgical events in the chat, or on the server that will be coming your way afterwards. So here we are. We've got Mel, we've got Amit, and we've got Sarah back. Fantastic. Amit, shall we come to you first? I think we should ask you the burning question. How do you do an embryo transfer? What kind of technique do you use? What do you do?
Yeah, well, I would say they're not too dissimilar to what Mel demonstrated, actually. So all of those things that she pinpointed to, her technique that she showed, I think is fantastic. And I pretty much, I do more or less the same as what she did. Now, because I'm very old and I did my first transfer probably a few years before Mel did, when we started learning transfers as a junior doctor in training, we were not told to do it under ultrasound guidance. So for a good part of, I would say, at least 5 or 6 years of my training, we did it completely as a blind procedure without ultrasound guidance. And having done both now, I can see why ultrasound guided transfers are better in a way, because it gives more reassurance to the operator, to the patient, to the embryologist, and as a team, everyone feels a bit happy that we've done the right thing here. So I completely agree that I think we don't have much option we got to do it under ultrasound guidance, and we will talk a bit later about whether transabdominal transfer is the ideal one and can be actually moved to transvaginal in a bit of time. The other important thing that I was taught as a junior doctor again was to make sure that you've got good light. And this is all very practical and goes without saying. A lot of people might say, what are you talking about? You know, good positioning of patient, but it is so vital. I've worked in places where the beds are not great and patients very uncomfortable and the leg is hanging off the side. So you don't really need all of that. So the most important thing is that patient with a super full bladder is very comfortable, that you as an operator are sitting in a good, comfortable chair. And those who work with me know that how fussy and annoying I get about how and where I sit and what height I adjust things to. But I think it's so important that if you can't see things properly, then how on earth are you going to do a good transfer? So good light, good positioning of patient and doctor. And the most important thing, and as this is especially to doctors and very many busy doctors across the world, is please, please, please switch your mobile phones off. Keep the mobile phone out of the way. I know it sounds like a daft advice, but I have seen so many people having their mobile phones ringing. You really don't need that distraction. And I think it's very impolite to have your phone ringing, however important you may be. As a doctor, please switch it off. Do not have your phones in there. No distractions, nice, calm, peaceful environment. And you know, there are two types of operators I see. I am a chatty one. I always talk to patients, and I sometimes I overdo it, but it's a question that I often ask patients saying, would you mind if I chat with you, or do you not want to? We can be absolutely silent. And I have a colleague of mine who works with me. He is silent as a Buddha. He doesn't utter a word. So I think we need to figure it out, that what works for patients and you and the environment. But that's the most important thing, that 20 minutes or half an hour will make or break people's lives. And I think as a clinician, you want to do the best that you can. So that's a crucial part of the whole thing. The other thing I wanted to mention with transfer is that, yes, full bladders are generally very useful to get a good transabdominal picture. Of course, when you have got retroverted uterus, then it may become slightly more difficult and tricky to bend your catheter to. And I totally agree that I exactly do what Mel does, is with my hand, I give generally a little tweak to my catheter and make it antiverted. And that was again taught to me by one of my old bosses who is now retired. And she always used to say that if it's most uteruses are antiverted, so it makes your life very easy. And if it's a retroverted uterus, just put it the other way around. So turn your catheter around and just go that way into the cervix, and then you can flip it back up. So that works absolutely fine as a strategy for me. What else? I made some notes about it. I completely agree that, I mean, having the more the additional stuff you start to add to your straightforward transfer, i.e. if you start putting in stylets, then your pregnancy rates almost drop down by 16%. And, you know, I will show you a little publication that shows, and going gradually up to using stuff like tenaculums, which again, I haven't used, and I totally agree that, you know, you can manipulate your cervix and uteruses with the speculum. But as soon as you apply tenaculum, it will generate uterine contractions, no doubt about that. And you could have a drop in your pregnancy rates by up to 46%. So there is enough data of sort of these stuff to say that the more you add to your manipulations, the worse the outcomes will get. And the main reason there is the uterine contractility, because uterus already has got contraction, even if you don't apply anything to it. And as soon as you irritate the uterus, it gets worse. So try not to do all of those things. I've seen people in various other parts of the world using sim speculum to do embryo transfer, to have two sim speculums and various fiddly bits and put people on left lateral. Please don't do that. It's not really necessary, and it will just make your life more difficult. I think that is probably about it. Otherwise, most of the stuff Mel said is absolutely correct from my perspective.
So it sounds like you guys have got a similar technique, and Mel's already mentioned that, you know, she uses the Shah Pro Ultra catheter. Amit, what catheter do you prefer and why? What's important about a catheter? Because you've already said that you don't want to introduce unnecessary bits and pieces into the uterus, but at the same time it needs to be smooth and easy, because we don't want that embryo exposed to, you know, a cold environment for any longer than necessary. So what's the sweet spot? What catheter do you use to try and get that balance?
Yeah, I mean, what you need in a good catheter is that catheter is easy to use and hasn't got too many fiddly parts to it. Two, that you can actually see it pretty well on the ultrasound scan. And ideally, you want something where you've got more than one options built into the catheter. And therefore, after having tried so many different catheters with different clinics and places that I train, I basically have ended up with Shah Pro Ultra. And the reason I use that as a standard, correctly, as Sarah mentioned, that the soft obturator is amazing, actually. And I can't remember having to use a Shah Pro with stylet in a long time. So for me, Shah Pro Ultra with obturator works because I can see it. I can see it very well. It serves and ticks off all the purposes that I want to do. Manipulate the shape because it's soft. It's got very clear markings onto it, so you know how far you go into the uterine cavity, other than the ultrasound guidance. So for me, it's a super duper catheter, and I use it every day, very much. Yeah.
Good to know. Did you want to add anything to that, Mel? What do you think is the kind of perfect catheter to get that balance right between not doing too much and not interfering with the uterus too much, but making it a speedy and efficient transfer?
I think exactly the same as Amit says, something that's very easy to see on the ultrasound, and something that's malleable. That particular catheter, quite often embryologists do bring out the catheter with the stylet, and as soon as you pick it up and you can feel how rigid it is, it's like, no thank you. There's very little need for that. These catheters, you can shape them, you can bend them, they'll follow the natural passage without causing trauma. A stylet, there's nothing worse than coming to a transfer where previous transfers or possibly IUIs have occurred and people have used a stylet, and you've got blind-ended passages caused by the stylet itself. Because if that's straight ahead, your catheter will always try and follow that passageway rather than the one that you want. So soft catheter in the 2-stage, so you can get it in place first and easily seen on the ultrasound.
So as atraumatic as possible then. Yeah. So one of the questions that's popped up in the question and answers section is, what are the benefits of 2-stage transfer compared to single-stage transfer? We know that many people still do a single-stage transfer technique and do it very, very well. What would the differences be? I mean, that's open to all three of you. What would be the benefits to a single versus 2-stage transfer? Would anybody like to start with that one? Sarah, do you want to comment?
Yeah, from a product design perspective or the use of the product, I think it's the safety of doing the 2-step transfer for patient and embryo. That's the way I would see it. I mean, 1-step was the beginning way before we introduced mock trial transfers, and Shah Pro encompasses the trial element within it, having the obturator for that routine 2-step. So by doing the routine 2-step, you can safely get a pathway to the uterus. The obturator hopefully blocks the mucus from going down the lumen where the embryo catheter would come into contact with it. So hopefully it'll be clear. It'll also keep that clear from bacteria going into it too. And then the clinician has hopefully got a nice clear pathway, and they haven't got to worry about taking the embryo under the heated hood out until they're absolutely ready and necessary to transfer. So if there's any complications when you're doing a single stage transfer, you may have to take that embryo back to the hood and it's been out for some time, perhaps losing a bit of temperature. So that's where I would see the benefits from the product design and usage. But I think, you know, from the clinician's point of view, Amit and Mel, you may want something to add to that.
Well, do you want to go first? on this?
Yeah, I have used single step catheters, and for the really easy transfers, I suppose the advantage is how quick it is. It's less time for a foreign body, if you like, to be within the uterus and any reactions that it causes. The difficulty is if the transfer itself is difficult, you've got an embryo that's out of its heated environment and potentially degenerating. I've also seen strange things where people have used the single step catheters, but in much the same way as they would use a double stage catheter, where they've inserted the catheter and then removed it, washed it, and handed it back to the lab to be loaded. And that, mind-blowing as far as I'm concerned. So yeah, 2-stage definitely for me, not single stage for that reason.
Do you think it's fair to say that perhaps as IVF has matured, 2-stage transfer has been something that's appealed to a younger group of or less experienced group sometimes of embryo transfer practitioners, because it's a more comfortable and kind of easier way to do a transfer, and they might feel more confident doing it that way?
Yeah, I mean, that's correct. That's exactly the point. But I also see, how I do, or some viewers would say that 1-stage transfer or single-stage transfer is often known as preloading technique, and the 2-stage transfer is called afterloading technique. So different part of the world use different nominations for that. Now, I was taught as a single-step transfer to start off with, and I still continue to do that in group of majority of my patients where I know who have had transfers before, who have had mock transfers before, or who haven't had any cervical surgeries, haven't had major myomectomies, and there are no pelvic operations and stuff done, like Mel said, that it's very important to actually read patients' notes before you actually jump on to do a transfer. And that is my biggest bugbear, that often people don't. They just don't. They just sit down and expect that the transfer will go well. Well, no, you need to plan things. So majority of the times, the single-stage transfer works absolutely beautifully, and it's so quick that before people even realize it's done and dusted. And it's not quick. Quick is not good because I've got something else to do, but less manipulations to the uterus. Where I see the advantage of 2-stage transfer or post-loading is training, which is a very, very important part that junior doctors need to learn. And how I do with them, how I train with people, and especially you could imagine how terrifying it is that there is this big burly man with beer standing next to you trying to look at your technique, and people automatically get a bit nervous. So I always run through everything with them at the beginning, how we're going to do it, what we're going to say to patient, who's going to say first thing and who's going to say second thing, so there are no discrepancies at what you do. And then 2-stage transfer is amazing because once they get the outer sheath and obturator in, we know that this transfer is going to be fine. They can move ahead and do the embryo replacement back into the uterus, so they feel very confident. If they cannot pass the outer sheath and obturator in, I step in. And I would say, well, okay, let me try, give it a bit more mold, change the direction of speculum, A, B, C, D, whatever tricks I have up my sleeve. And if I then get in, then I would do the afterload. That way, you're not doing any harm to patient. You are there, you are teaching and training the next generation, but you're also doing the best that you can for patients. So I think there is that little additional advantage, the training aspect of the whole thing, where 2-stage works really well.
Fabulous, thank you, Amit. I have a question in the chat around use of ultrasound. So how much advantage does an echogenic catheter offer you? Does the image look particularly different?
Oh, immensely. Yeah. Sorry.
Yeah.
No, there's a huge difference of a good echogenic catheter. It's priceless. I mean, your manipulations, ability to do things quicker, it all adds up. So I would not use anything that is not echogenic anymore. I think that's for granted. Yeah.
And is the image very, very different?
Yeah.
Yeah.
You can see.
Fabulous. Fabulous. Super. Mel, I think you've already mentioned this. This can be a controversial one. Do you clean the cervix routinely prior to embryo transfer?
Yes. Yeah, but just with normal saline, nothing more, nothing less. I've used gauze on sponge holders, cotton wool, large cotton bud tip things. Personally, I prefer a bit of soft gauze because I think it helps clean the cervix, and especially if people are taking their progesterone supplements vaginally, it's good to be able to remove any residue. But for me, yes, definitely I clean first. Amit?
Yeah, no, absolutely. I mean, it's a very essential part of the process. Now, how much you clean varies from a clinician to clinician. I've got colleagues of mine who would use religiously 10 swabs, and he's listening to it and he's probably laughing at me now because I laugh at him when he does that. But he says that it is not the 10 swab. It is that it allows him to focus, calm his mind down, and he's doing a job. And that's what it's like, a little process that he gets into. I don't use X number. It all depends on mucus or the pessary crumbs that are hanging around, whatever you need to clean out, you do that. And I often tend to use a very tiny amount of gel in patients who find speculum insertions very difficult, because the last thing you want is a patient who is very uncomfortable and moving around, as a moving target is not good for an embryo transfer. So, so cleaning, yes. I don't tend to use buds and put them inside the cervix to remove mucus, because that often adds up to a bit of bleeding in part. And if you're going to do that, then you've got to put that into saline or culture medium or whatever you do. So it has to be wet. You can't use a dry swab sticking inside the cervix. What I've learned with time from a colleague of mine again, is that what I do is that while the catheter is getting ready and I've started my cleaning and I'm happy with the cleaning, then I take a little wet gauze and just put it against the cervix in there. So it's just sitting up there. While the catheter comes, then I take it out. And what it does, that it sucks up all the mucus. So it doesn't, you then don't have to do a deep digging inside the cervix, which you can avoid doing that. I mean, it works most of the time, may not work for everyone, but generally, yes, cleaning's a vital part, yeah.
And would anybody advocate anything other than just some saline to do that job? I have heard of people using antiseptics and sort of washes and all sorts of things. Are we just using some saline?
Yeah, sterile saline. I know people use culture medias and stuff like that, but I think it's very expensive, unnecessary. It doesn't give you any other advantage. And please don't use stuff like betadine and Savolone, because that is, you might as well just throw the embryos down the drain. There's no point. Helen, can I quickly show a little video of how echogenic catheter, and it's a Shah Pro catheter, looks like?
Yeah, absolutely.
The question of what does the, how good the catheter looks like. So if you look at this little video that is coming up, you can literally see the tip of the catheter advancing, and this is a one stage or a preloading technique used. You could see the endometrium very clearly, and you go approximately in the middle of the uterine cavity. Make sure that the tip of the catheter doesn't touch the fundus, because that is often leading to a lot of endometrial lesions and bleeding. And then once you've sort of pushed the embryo into the uterine cavity, you can gently take it out. So that shows you how clear what a Shah Pros will look like on a scan.
That's a really, really fantastic image, actually. It's really clear. Brilliant. A question maybe for you, Sarah. What do you do with that bung on the catheter? Do people use it or not? What do we do with it?
Talk about the cervical stopper.
Yeah.
Yeah, I thought you was. So it's desired or not desired. You don't have to use it. It's there for those people who want to use it, so that they say, so you got the depth markers. I've seen some questions on there, and a measurement before of the cervix would be useful, and so you want to know how far you want to push the outer part through. So this isn't designed to go into the uterus. You should just see the obturator tip protruding just at the opening, but you move this up and down to wherever your desired measurements are. So this would stop at the opening of the cervix, so it's almost like the plug, but don't push in too far because it might eat it, if you like. But you don't have to use it. I know some customers just push it back, but it's securely easy enough to move. And there's when it comes out the packet, not because I've been playing with it, but it's just, there's a little notch there which tells you which way the curve's going as well.
Very clever. Okay. Very clever. So if people don't want to use it, it's not going to get in the way, but if they do, it will help them position to the right depth.
That's right. Yeah.
Perfect. Wonderful. Catheter bung. that's my terminology. Sorry, Sarah. Got an interesting question about what embryo transfer technique is best to enhance embryo implantation potential. Who would like to tackle that first? Amit, go for it.
You could see me itching to go, is it? No. Well, I think what works for you, as Mel said, the technique that you have honed and perfected over the time, and if it works for you and it gives you good outcome, don't change it. I don't see the point. Now, what techniques works the best? Well, there are many ways to skin a cat. What works for another person may not work for me. So I don't think that there is one ideal way, but the technique that is least traumatic, it's quick. You don't have to do multiple kind of manipulations. That is the technique that works the best. I mean, I don't think that for me, whether I do a preloading, which is single stage, or whether I do a post-loading two-stage process for training mainly, makes any difference. What I have seen with my practice, that because I'm so used to one-step strategy, as I would then go, say, if it's a very difficult transfer and I can't get it through, then I would have to give the embryo back quickly to the embryologist, and that's where the issues that were raised, that, you know, the temperature and pH and all of that starts to drop and change, and that's not great. So you then bring in another intervention, which is a outer sheath or a stylet or tenaculum, then it starts to get worse very quickly. So try and avoid all of those things if you can. And there is a good little stuff that I'll quickly show you again, which shows, and if anyone wants to be interested into looking at a difficult embryo transfer analysis of over 7,500 embryo transfers, it's a very, very good publication. It's about 3 years old, in fertility, sterility, an excellent article to review. And what I wanted to show you was the drop in pregnancy rates, as you can see here, that if you do a single stage technique, no additional maneuvers, and as you start doing outer catheter sheath or Wallace stylets or tenaculum, it starts to drop pretty quickly. So quick one and atraumatic one is the best.
Excellent. Thanks, Amit. I've got an interesting question about how much training embryo transfer practitioners get. How often do you guys get an update and a refresher on your training? Mel, is it a requirement to have routine embryo transfer training once you're signed off?
I think it's more a requirement to have your competencies assessed. So rather than go for retraining, unless something significant has happened. Now, most clinics have got databases where you get your results based on practitioner. You can closely monitor if any individual practitioner's rates have dropped for any particular reason, which would indicate that retraining was required. But other than that, I think competencies, and I think purely because majority of the time you're constantly training somebody to do the abdominal scanning, it's making you constantly reassess your own part in the proceedings anyway. And I actually find it quite astonishing how many people I've had that have supposedly been trained to scan, and I've got no idea what image it is they're seeing on the screen, because it's not anything that I can interpret. And actually, by the time you've taken them back to basics to point out what it is you want to see and therefore teach them, one, you get a much better transfer. It was much better for the patient. That practitioner themselves then learns, so that when they move on to do embryo transfers themselves, they know what they're looking for. So I think the constant process of teaching other people, having people observing you, is sort of retraining in itself, if that makes sense.
That does make sense. Amit?
Yeah, no, I agree completely. So once in a while, every year, maybe for about 1 or 2 transfers, and that is just me, I ask my colleague who I've worked with for a long time to actually come and observe what I'm doing. And I would ask the patient, would you mind if so-and-so comes and looks at what I do? And I think it's amazing, and it's really good, because 2 trained people, if they look at each other, and it's also kind of helps me from, if something happens in future, then at least I can say, well, look, I have been observed. This is not a legal requirement. It is not technically necessary, as Mel said, because you're constantly training other people. So you are going to get refreshed, but it just makes me feel a bit better. That saying, okay, another senior guy or a person has actually come and looked at my transfer, and I haven't deteriorated dramatically, or I'm not doing something completely crazy. So it helps. The other bit I just wanted to bring up is that, you know, a lot of people, when they trained, and I think it applied to me as well, we were asked to do 50 IUIs or 100 IUIs, and then you were allowed to go into embryo transfers. And it's really interesting that I thought that this is amazing, that you have got the ability to handle a catheter, and then you graduate up to transfers. And I think it's the right path. But there is a amazing publication that came from Massachusetts with a very, very well-known embryologist, Catherine Rakowski, and her team. And they have shown that the whole training process of doing IUIs and graduating to embryo transfer makes no difference whatsoever. People are still as bad as what they were learning embryo transfer. So what they suggest is that you actually, if you're going to train people for embryo transfer, then just train them for embryo transfer. Because IUI is a bit different, and you could get away with a few things, while with embryo transfer, that precision is very vital. Yeah.
Okay, interesting. Thank you both. A question that I think might be good for you, Sarah. Is there a benefit in measuring where in the uterus the embryo is placed? And another question that kind of ties in with that, is there a benefit to using an echogenic catheter in that instance?
Sorry, so just so I understand, they want to know, I'm quite sure where we're going with the question.
Trying to work out where you actually position the embryos, where you expel the embryos within.
Okay.
Yeah.
Right, sorry, yeah. So it's usually 1 to 2 centimeters away from the fundus. That's where they would expel. I think it varies from person to person, and Amit and Mel will probably concur with that. But it's somewhere between 1 and 2 centimeters away from the fundus.
Agree.
So there is a perfect spot for position the embryos. And what about the part about the echogenicity of the catheter? Is that important in knowing you're in the right place, for example?
Definitely, and I think there's some papers about mid-implantation points which actually use the echogenic or 4D ultrasound or something that really, you can see obviously on 2D for the 2, but you can see where you are against the uterine walls perhaps a bit better if you've got a 3 or 4D scanner. But yeah, so it really does help make sure that you are not touching that fundus. If you're going in with a non-echogenic catheter and you're using ultrasound, I believe you can see a little bit of movement, but it's still not completely accurate. And as Amit showed that great video earlier, you can see exactly where you are with the ultra echogenic bubbles with the Wallace catheters.
Yeah.
Here's an interesting question. If you're not happy with your first pass of your catheter, can you withdraw and try again with the same catheter, or should it go back to the lab to reload? Anybody want to tackle that one?
Well, I think I'll see on ultrasound. Sorry, Sarah.
No, I was just going to pass it to you because of the clinical side of things, but yeah.
Yeah, I think the only time you wouldn't be happy, I suppose, with the passage of the catheter is if you manage to get a bit of stenosis or a difficult shaped cervix and you can actually get the catheter in. But once you've got your catheter in place, unless you went to insert do the actual transfer and the embryo didn't leave, that could be the only reason I would see that you'd have to actually repass a catheter, because if you're constantly looking at your image, you're adjusting it anyway. So if for some reason the machine turns itself off, or the person doing the scan has lost their image for a second, most of the time you know to stop what you're doing until the image is back. Nobody, I can only presume, Amit, I'm sure you'd agree, would just carry on inserting a catheter if you weren't happy with what you were seeing on the image. So there would be no reason to really go back in again unless the embryo had been returned.
Yeah, agree. Yeah, completely.
Fabulous. I think we've got time for maybe one or two more questions. I was going to ask Mel and Amit for one golden rule, one golden hint or tip for embryo transfer from each of you.
Oh, Amit, you first. Well, I think.
Keep your mobile phone out and fill up the bladder, not yours, the patient's.
Brilliant.
Yeah, and keep the tenaculums in their wrappers and nowhere near the patient.
Fabulous. That's great. So as we're starting to wrap up, I think a good question that's come in that we can finish off with is, what's the future for embryo transfer? Where are we going to go with embryo transfer in the future? I'm sure that's a huge question. Who wants to have a go at that first? Go on, Amit.
I can have a go. Future is bright. It's orange. No, I'm sorry. Well, I mean, you think of it, that not a lot has changed with the embryo transfer technique over so many years, and we kind of get used to a way of doing things, and we keep doing it successfully, then why change it? But you know, the one thing that is, I think, coming in, and Sarah brought it up before we started this, was about the transvaginal ultrasound scans. That gradually a lot of clinics and clinical practices are moving at doing transvaginal scan-guided embryo transfers, where you don't have to fill up the bladders. If you've got retroverted uterus, it is much easier to see. The images are spectacular, and it actually works really well. The downside of doing that is that it's a bit more fiddly. You have to be slightly more dexterous. You have to handle catheters, scanners, speculum, assistance. But I think that it is doable. I have been doing it for a little while now, and you struggle initially, but eventually you get quite comfortable doing this. And I know so many clinics who do it as a standard process. But yeah, that I think will change things in future.
Mel, do you have any idea where embryo transfer might go in the future?
No, I agree with Amit that very little has changed other than not using ultrasound guidance to using ultrasound guidance. I think there's going to be more focus on the optimal environment, possibly vascularity of the endometrium. My only request, which isn't specifically for transfers, but just in general, is for somebody to invent a speculum that is particularly good for posterior lying cervixes, because they all open upwards and they're an absolute pig for some patients. So yeah, a bit like a left-handed potato peeler. We need a retroverted speculum, I think.
Maybe Sarah can have a word with her colleagues on our women's health side, and we can see what we can do with that. We'll come to you for some design ideas, Mel. Brilliant.
Thank you.
I think that's about all the time we've got really for questions now, and I'm sorry we haven't been able to get to everybody. If there are questions, we'll record those questions, and we'll see if we can get back to everybody with some answers. And I think I can probably hand back to Emily now for a few words before we end today's webinar.
Yeah, thank you, Helen. That's been super. I've really enjoyed that. Thank you so much to all of you, Melanie, Amit, Sarah, and Helen. It's been our first webinar with a live demo, and we were a little nervous beforehand. I think it's fair to say as to how it would go. But Melanie, you're absolutely super. I have to say you were cool as a cucumber doing that demo. It's been fabulous. And a big thank you as well to Dr. Amit Shah. I think we've already benefited today and learned a lot from your huge experience and knowledge of embryo transfer. So thank you so much. A big thank you to Sarah for presenting. A big thank you to Helen for seamless chairing and hosting there. You've been super. And a big thank you to Danielle. You can't see her, but she's there in the background. She runs the webinar. She does all the production. She does it brilliantly. That's why you don't know she's there. She also does all the huge amount of work preparing this webinar and marketing it and advertising it and making sure that you all knew about it and were able to join today. So thank you very much to Danielle.